All right, it's great to see so many of you here. I know we'll have folks trickle in. Thank you for coming to our all-provider meeting this evening. It's great to see a good turnout, and again, we'll look forward to more people coming in with food. I'm going to kick us off with a brief reflection here, and the theme on this is change. In a time of drastic change, one can be too preoccupied with what is ending or too obsessed with what seems to be beginning. In either case, one loses touch with the present and with its obscure and dynamic possibilities. What really matters is openness, readiness, attention, courage to face risk. You do not need to know precisely what is happening or exactly where it is all going. What you need is to recognize the possibilities and challenges offered by the present moment, and to embrace them with courage, faith, and hope. In such an event, courage is the authentic form taken by love. And this is Thomas Merton, a monk of many, many, many years. Appreciate the opportunity to see so many of you this morning. Welcome. Enjoy the evening. We've got a very jam-packed agenda for all of you. At this point, I'm going to transition to Dr. Nolte here for a brief transitionary comment to our new CMO.
Mitesh has been working too hard because he did say this morning. He always works too hard. So I gave my last hurrah last month, but so this is my last hurrahs to introduce our new CMO, Steve Campbell. So Megan was just commenting that she's so happy that Steve has chosen to continue the time-honored tradition of the Providence CMO wearing cool clothes. As we recall, our previous leader, Tom Yettman. So Steve is a Canadian. So all the Canadians, raise your hands. Canadians are awesome. We have so many great Canadians in our group. So here's one more. He trained in Vancouver at the University of British Columbia, and then he went and did his, the American somewhere else in Canada, his residency. Sorry. But then he was at the Mayo Clinic for 18 years, and he was a small town family doc, so he did a work that a lot of us do, but he also got really involved in quality, which we're very excited about. And then he went to the Everett Clinic for a couple of years, took a great opportunity in California that didn't quite pan out. He did nothing wrong. And now he's back with us. So that's my last hurrah. Steve.
You know my story better than I do. And it saves me telling it again, so thank you. I saw a show of hands for Canadians. Along the same lines, how many hockey fans are in here? Yeah, there's like 2 Game 7s tonight. Just saying. And last I saw it was 2-1 Bruins. So if any of you are recording it, sorry about that. Before we get started, so I'm looking off of super tiny stuff. I said to Cynthia, I said, "Oh, the screens are way behind, so I think I'll need the paper." And need to update my lenses, I think. We do have a busy agenda, one that I think is a very good one. Thank you, Mitesh, for doing the reflection. We're going to introduce some of our new providers. We've got some awards as well. And then I think you have the agendas on your tables. I'm going to just give a little spiel on patient experience. It comes from my days in Minnesota and actually my couple of years at Everett Clinic as well. And then Dr. Cook's going to talk about some call questions, which I think he's going to ask some great questions that will probably get the room buzzing. And I'm looking forward to that. Pharmacy update, which will probably also generate lots of discussion. An update from our Express Care partners, and then the new weight management program, which Sean and Melissa are going to share with us. And some of you have heard a little bit about this, and some of you haven't. It's a great program, and so he's going to do a good job of sharing that with us. And then if we have just a little bit of time at the end, I'll just tell you, I'm that guy, that this room will be empty at 8 o'clock. If it's not, it's because you chose to stay here. But if we have a little time just for sort of open Q&A, you know, I'm the new guy, I'm the dumb guy, so you can ask me anything, I probably won't know the answer. But Cynthia's gonna write down questions that we can't answer, either me or the rest of the team. Pleased to introduce our new providers that we have here. If you see your name, feel free to stand up. Save your applause till the end. We have quite a few of them. Dr. Cynthia Warner from cardiology, Courtney Schick from urology, Matthew, and I apologize, Langdyke from behavioral health, Anna Sturm, Dr. Carlos Garcia, Luann Sines, Dr. Elizabeth Barrera, Heather McGregor, Julie Hornsby, Dr. Douglas, is it Greer or Grier? Greer, I had a 50-50 chance. Dr. Sharma, Lisa Ramirez, Dr. Chalam, and Dr. Gomez. So if you're here, thanks for coming. And welcome to Providence. Now, Dr. Gomez is here, right?
Yes.
So Dr. Gomez is our new sports medicine physician, and he's going to actually he's going to come up for a few minutes and talk to us, share with us his vision for his practice, create some awareness, and kind of let us know what he does and how what we can do to support him.
So they actually gave me a mic.
Excellent.
So the meeting initially was optional. And then I got a little bit of peer pressure to show up. They said that they were going to put my picture up. So then I was like, shoot, I guess I have to go. And then by the end of the day yesterday, they said, well, we'll let you talk too. I was like, oh, great. All right, no pressure. So in terms of sports medicine, does anyone have any particular questions about sports medicine? I mean, I think I can give you guys the quick 1 or 2 minute synopsis about what it is. In short, it's musculoskeletal medicine, primarily involving the upper and lower extremities. I don't do a lot of back stuff. That usually, the practices I've worked with go to orthopedics or physiatry. I don't do EMGs, but I plan on doing a lot of diagnostic ultrasound. We're going to have a really, really cool Samsung ultrasound machine. I trained with Swedish, and I trained with 2 Mayo Clinic trained sports medicine providers, Dr. Porjo and Dr. Henning. I'm RMSK certified, if that means anything to anybody. It's basically I had to do like 150 or 200 scans with a proctor, submit the reports, and then take a test. And really, in terms of diagnostic ultrasound, I feel really comfortable looking at shoulders, elbows, wrists, hips, knees, and ankles. So all the routine extremity stuff. I'm okay at SI joint stuff again, but I think people kind of conflate that with cervical spine stuff sometimes, so I don't think I'm going to see a lot of that. Lots of ultrasound guided injections, so any of the major joints I feel really comfortable injecting. Typically it'll involve Kenalog, in certain cases Depo-Medrol, and betamethasone. Whatever, if you guys have a preference and you send me an injection, I'd be happy to do whatever you want, but typically it's going to involve those. We're also going to get a PRP program off the ground. I know that there's a flyer on the table. PRP is platelet-rich plasma, and I think it's relatively new to Snohomish. Basically, it involves taking a little bit of the patient's blood, spinning it in a centrifuge, and re-injecting the plasma, which has a higher platelet concentration into joints and into and around tendons. There's really good evidence that it works for knee osteoarthritis, particularly grade 1, Kellgren-Lawrence grade 1 or 2. In fact, it's been shown in the Journal of Arthroscopy to be better than HA, or hyaluronic acid, for Kellgren-Lawrence grade 1 or 2 knee osteoarthritis, which is a really difficult journal to get published in, and if it met that level of standard, I think it's a pretty robust, I guess, recommendation that a lot of people are making. By extension and by extrapolation, I'd be happy to inject PRP into hips and other joints as long as patients are okay after we have a conversation about the risks and benefits. Risks being much more tolerable than, or it's better than corticosteroid because it doesn't have any catabolic effects. I know I'm kind of rambling about a lot of stuff that I like to do, so if there's any questions, I'd be happy to kind of talk about any specific questions that the group might have. Otherwise, I'm just going to sit down.
I've been asked by my peer to ask what high school you graduated
Yeah. So someone asked me that yesterday. I should have prefaced this entire thing with, I know I look really young. I've gotten that about 10 times since I started. Yeah. Oh, high school, it's Arizona. It's a high school in Arizona, so most people probably haven't heard of it, Safford High School. Yes, absolutely. There's a new AMSSM concussion statement. Just came out in 2019, and the people that I worked with at University of Washington, Kim Harmon, I don't know if that name rings a bell, helped. She was basically the point person for that statement. So I feel very comfortable doing concussion. I would say in terms of referrals, I am pretty comfortable seeing any patient age limit. Anyone younger than 6, I think they should go to pediatric ortho, but 90% of the pediatric patients I see are going to be concussion. There might be like a complicated apophysitis that ends up on my schedule, but the rest is probably going to be concussion. And I'm going to build networks to try to make a really robust referral system to get, you can get vestibular symptoms and things like that. So I'm planning on building a network for that. Anything else?
What age group? What's the youngest age?
6 years up to folks with osteoarthritis who want to push off a total knee or something like that. Totally. Yeah, and actually I'm looking to get involved with a local high school team. I love football coverage in the Snohomish area, so if anyone has any recommendations, my email is andrew.gomez2, the number 2, @providence.org. So I'd be happy to field any more questions, or if you have any teams that might need a sports doc, let me know. All right, thanks.
Thanks, Dr. Gomez. I get the honor of presenting our Above and Beyond Awards this evening. These providers have been observed going above and beyond their clinical duties to meet an extraordinary need when faced with that need. These needs can be patient, staff, or colleague needs and present in a variety of ways, often unexpectedly and requiring in-the-moment action. These providers step up and get their hands dirty to help whatever the situation is in front of them at the time. They don't look for thanks or payback, they just help. So we have 4 of them tonight, and I don't know if all 4 are here. First one, Dr. Baudry. No? Mueller? I don't believe Dr. Camber's here tonight. I was told she probably isn't.
She's on call.
Is she? Maybe you can take it to her then. Keith Erickson. Caught you off guard. And Marilyn Borromeo Wesner. Is she here? And I'm going to speak a little bit about the essential elements of an outstanding patient experience. And this is the 4th organization I've been with in, 21 years. And patient experiences always kind of generate some emotion for various reasons. And so what I'm going to do is try to at least build a little bit of a business case why it's important. I'm really, can you hear me if I just talk out here? Yep. Okay, because it's easier for me to just look at the slides than the small ones here. So a business case for prioritizing patient experience. Impress upon you, and most of you know this, service excellence is a team sport. Touch on some of the tools to succeed. And then what are the metrics we're going to use in order to monitor our success? So starting with the business case, the why. Well, number one is fulfilling our promise that we have with all of our patients every day. Patient compliance, and I'm going to share some. Is that better?
You have to pass the music in there.
There we go. All right, I'll use this. Patient compliance, and I'm going to show you some studies that actually demonstrate this. Correlation with clinical outcomes. Increasing competition. You know, Optum's going to be for real here shortly. Kaiser's kind of that big gorilla that's sitting quietly right now, but they're not going to do that for a long time. So it's a more competitive marketplace, and some of you have heard me say this. We're all smart. We're all board certified. You know, we all have all the initials after our name. The differentiator often is, what was the experience of care like for our patients? And then, you know, love it or hate it, you know, we all know this is online, whether it's, you know, using something formal as Press Ganey or just go to Yelp, go to Vitals, and I'll share a couple of quotes that are right off, hot off the internet. So let me just share some data on patient compliance or patient adherence. This is a little hospital centric, but for each 10-point decrease in the doctor communication rating, the prevalence of poor adherence increased. And these are studies that came out of a diabetes study in California. And then compared with patients who offer higher ratings, patients had poorer adherence when they gave healthcare providers lower ratings around decision making, around understanding their condition and their treatment, and eliciting confidence and trust. This shifts more into the ambulatory world, again around physician communication, caring communication between providers and patients has shown to positively impact clinical outcomes around metabolic complications in diabetics, improved glucose and LDL control in diabetics cared for by physicians with higher empathy ratings. Same with the other one, higher empathy ratings. Patient assessment of physician communication associated with improved patient medication adherence and reduced incidence of malpractice claims. And there's actually a few interesting studies that show the lower the patient experience scores, the higher the complaints and the malpractice claims. And that one always gets my attention. How about some of our outcomes data? Well, here's, this one's for central line infections. And so patients who, when asked, did they always receive help when they wanted to? Patients, and it's in quartiles, so those in the worst quartile about getting help when they needed it had the highest rate of vascular catheter-associated infections as compared to those in the best quartile in which they rated higher that they received help when they needed it in the hospital. Discharge instructions. These are readmissions, so heart failure on the left, pneumonia on the right. And essentially the better the discharge instructions, the lower the readmissions, again by quartile. And then healthcare associated infections, both C. diff and central line infections again, when compared to overall rating of a hospital. The higher the rating, the lower the infections. So so again, you know, there's starting to be stronger and stronger ties between clinical outcomes and patient experience. Here's some stuff right off the internet, and sorry, Dr. Nolte. I've been a patient of Dr. Nolte since 1990. This came off of vitals.com. I love how she greets me with a hug and is generally concerned about my health. She always follows up with a note or a call to see how I am doing. And the one on the right, I can just tell you this wasn't a Providence Medical Group clinic. I deleted out who it was. Failing patients daily. I went to blank clinic 5 times looking for relief from a chronic sinus infection. After that, I had a series of doctors who came in, sat down at the computer, asked a couple of questions, and prescribed medicine. They all gave me the same medicines. Only once did the doctor even look in my nose or actually physically touch me. Very little eye contact was made. If you want to spend a lot of money to feel unimportant and unnoticed and even invisible, go to this particular clinic. And again, these are online. This isn't from Press Ganey. This is what's out there. I mean, that last one, that hurts. Wasn't us. Other areas where patient experience, enhanced patient experience helps. Again, I touched on malpractice risk, retention and provider satisfaction. Insurance contracting, we're starting to see more of our commercial payers tie patient experience to part of the contracts. Patient loyalty is probably one of the strongest ones. Studer Group in particular has shown that overall ratings in the 9 or 10, so those top box has the highest correlation with patient loyalty. Certainly less patient complaints. And then down to the bottom, again, this is part of more of the Medicare programs as well. Patient experience is a team sport, and I think most of us in this room know that. I think when I started in practice, I thought, selfishly it was all about me. Everything is what happens in the room is all that matters. But we are all set up to succeed, or alternatively, we could be set up to fail. What was the experience of scheduling, of checking in, of the MA rooming the patient, our interactions with the patient? How about when they went to lab, x-ray, any follow-up or instructions afterwards? There's lots of things that come into the patient experience. We own a small part of it, but the most significant part of it, because we can take a crappy experience and we can turn it around and make it great. We can also do the other way around as well. And so, as we look at patient experience scores, not only are we all getting our individual numbers, we're also looking at the other pieces that go into this. Again, scheduling, rooming, etc. In order for us to succeed, it doesn't happen just by fluke. There are deliberate things that are necessary. If we as an organization feel that patient experience is important, there has to be that commitment. I strongly believe that there needs to be a physician champion. And I would like some help in identifying who that could be. With that, the role has to be clear. That champion needs to be trained, needs to understand the world of patient experience. In turns, train our physicians, help just give us the tools. Just like when we went to medical school, we were given the knowledge and the tools to do our trade. Same with here. What are the little things that maybe we can do a little bit better that may be very small? Measure performance, provide the feedback, use data to drive results. We physicians in particular, we love data. Celebrate successes. We in healthcare don't do that enough. We don't celebrate the small wins. We're sure good at pointing out when we don't do well, but we're not very good at celebrating the small wins. And then address the perpetual low performance. Help those that are really struggling. Just 3 quick little stories. These are real stories about 3 physicians who were struggling with patient experience. On the far left, it's a surgeon who was in the 1st percentile. There's not a 0th percentile. So this particular surgeon met with, it was a him, met with his medical director. They set a plan together, made 3 changes in working with their patient experience coaches. At least when this was done, over 6 months following, it was close to the 83rd percentile. The next one, a specialist also in the 1st percentile, met with both the medical director and the CMO, together set a plan, made some small changes, and again, was at the 77th percentile, at least for the last 3 months when I put this together. when I was at the community practice at Mayo, our chief medical officer, she was a pediatric ENT, and she had to carry the flag for patient experience, but her patient experience sucked. You know, it was 60th percentile or so. I mean, it's not terrible, but when you're going to be a champion, you know, you expect it to be a little bit higher. So we actually had the team work with her, she and her team for, I think it was 2 days. And she told me afterwards she had to make very few changes. It was mostly around the team around her, setting patient expectations, etc. And she rose to the 90th percentile and stayed there for quite some time with very little blips. And the thing, again, I most remember about it is how she said there was only a couple things that were small that she had to do different. So, you know, this isn't about going to charm school. It's just some little things that if we don't know we're doing it, you know, we don't know what we don't know. So measuring success. So here, the present metric at a high level is the overall provider rating. And for those of you who don't know, is it 0 to 10 or 1 to 10? It's 0, so 0 to 10. And a 9 or a 10 is considered top box. And what's measured is the top box score. So the goal for our region is 83.7% top box. The struggle with that is if you get an 8, it's as good as a 0, unfortunately. But a 9 or 10 gives you top box. And that's our 2019 goal, 83.7% top box, all provider rating. Just to put that in perspective nationally, that's a 35th percentile. So 2/3 of the country will be better than us in what is a moving target. You know, we're going to get better, but everybody else is getting better too. And that certainly makes it challenging. The goal is to be the 70th percentile by 2022. So there was these incremental goals put in place because it's not realistic to go to 70th percentile in 1 year. It's just not realistic. So we know we're accountable to that system goal, but where the team has struggled is, well, how do you make the overall provider rating better? And it reminded me of one of my kids' hockey coaches a few years ago when his answer to what do I do differently was, well, just be better. So we looked at what questions do our patients answer that actually has a strong correlation with the overall provider rating. And in fact, it's the one that says, did the provider explain things in a way that I understand? And so, therefore, if you nail that one, the overall rating will probably do well on that one too. Again, it has the highest correlation, or one of the highest correlations. So what the team's going to be doing moving forward is really helping us focus just on that piece. It's much more doable. Press Ganey provides some great tools to help us with that and some of the other questions as well, but that's the one we're going to focus the most on. The assumption being, again, based on their correlation, if we do well on this one, we should do well on the overall rating. Now, here's the other piece to it. I don't know if it's on the next slide. It will be. Is not all specialists are created the same. So, for example, a physiatrist to be at the say the 50th percentile, it's a very different raw score than a pediatrician to be at the 50th percentile. And so we're going to shoot for percentile. That's a different raw score for each specialty, but same percentile. And Press Ganey has reassured us that, yeah, given the kind of the makeup of our practice, once it's all thrown in the soup pot at the end, it should spit out with kind of where we want. So here's some examples, and you'll see there is some difference. Probably the physiatry. So this is around provider explain things in a way I understand. So physiatry to be at the 35th percentile means a 90 raw score, 90.4. For a pediatrician to be at the same 35th percentile, they need a 93.8, almost 94. So that might seem like a small number, but when you get up at that level, the shift, it takes very little to shift percentiles. And so that was recognized, that there may be a degree of concern that we're trying to put everybody, compare apples with apples, or apples with oranges and bananas, and put everybody on, compare it with their specialty across the country. So surgeons are being compared with surgeons, family docs being compared with family docs. So to summarize, what's not here is today there's no tie between patient experience and our compensation, and nor will there be for the rest of the year. The comp committee is working on kind of how all of this works, but for now, it's how do we put together a shadow model, put it in place, and then see how it plays out through the rest of the year. And if it looks like we're doing this well, how do we implement it? If it's not, then how do we regroup and ask the question differently? Again, for us to succeed with our patients, physician leadership is essential, and providing the support and the tools for success also is essential. And Erin's at the back, and she's our manager over patient experience, and is an absolute expert at all of this, and is open to providing whatever resources are needed to help those of us who might need a little help in this area. So thank you. I'm happy to answer any questions before I turn it over. I think Jay is next, but I'm happy to answer any questions that anyone might have.
I have a question.
Yeah.
So, my experience as a pediatrician, since you brought us in the example, is that my patients don't have the time to answer that very long Press Ganey questionnaire that they received. So I think that if the questionnaire that they received was shorter and more to the point of the things that we're trying to track, we might get more accurate data returned, because I get a very low percentage of my scores returned to me.
And that's been a concern about is the N. What's the N that we need in order to be directional, and so that's something that Erin and I talk about a lot. So why is in some areas an N low? Is it because of the survey itself? Is it because how we distribute it? What other factors play into it? So I get it, and kind of that's one of the things. That's why we get this kind of shadow period, because if we find overall half of our providers have an N that's too low, okay, this isn't going to work. And what do we do differently? And maybe it's the questionnaire itself. Other questions? All right, well, thank you. And I will turn it over to Jay.
Steve, maybe before we transition over to Jay, a couple of words from last quarter that carried over that we didn't get a chance to do earlier. We wanted to acknowledge Jeff Scott from last quarter. He's here. He was not last time, so we're gonna thank him with us. Probably acknowledge Dr. Earhart over there. He was also acknowledged last quarter, and he grabbed his award, but we should still acknowledge his presence.
All set?
It's all yours.
Great, thanks.
Thanks, Steve. So I know many of you, but I don't know all of you, so I'll introduce myself. My name is Jay Cook. I'm a recovering vascular surgeon. I'm the chief medical officer at the hospital here at Prov Everett. I've been in the community since 1991. I've been CMO at the hospital for almost 2 years, and as it happened, I became CMO at about the same time the vascular group was transitioned to PMG. So I went out of the group and became CMO simultaneously with the rest of the guys coming into PMG. So I've not had the pleasure of meeting many of the, or not all of the primary care docs. And so I appreciate the opportunity to talk to you tonight. And I think, Cynthia, can you start this? Even though I'm a hospital-based CMO, and I'm a hospital-based surgeon by training, my remarks are really going to be focused and directed mainly to the primary care docs here, and to help all of us kind of understand the power that we have to influence and to have a real connection to our. And this is, our mission is very special. I think that it's why many of us came here and why many of us remain here. We all, as Steve and others alluded to, you're all smart people, you have opportunities, but I think that our mission really speaks to a really important part of all of us. And I'll just read it here because I think it's important to articulate it. It goes as expressions of God's healing love, witnessed through the ministry of Jesus. We are steadfast in serving all, especially those who are poor and vulnerable. And I want to, and as I mentioned, the purpose of this is to kind of point out how you all have more power than you think to help align our community to our mission here to serve everyone in our community, particularly the poor and vulnerable. And so, there are few people that are more vulnerable than those who come into our emergency department who are acutely ill or injured. And many of these vulnerable patients also happen to be poor, although not all of them are. Some of them are our friends and family. It is, they are stressful, they're inconvenient, they're often complicated, and it's in a challenging environment. And many of the folks many of the providers who are taking call have to work the next day, and there aren't too many of people who still take call. I've listed some in PMG, and a couple dropped off here. I'm not sure why. I want to call out our ENT colleagues and Dr. Earhart, who are always available for particularly airway emergencies that are very acute, and also our plastic surgery colleagues who do a lot of work in the ED, particularly with hand injuries. But there are a lot of PMG providers and also non-PMG providers that provide these services. And this kind of work really challenges your commitment to serving the poor and vulnerable because of the stress and the inconvenience here. And it doesn't help that our ER is for a long time been the highest volume ER in the whole state of Washington, and one of the highest on the entire West Coast. Also, there are seven other EDs that frequently want to transfer patients to us. And it's also the strategic vision of the hospital to become a more robust regional referral center and trauma center. So it is, it's really incumbent on us, meaning the hospital side, to engage all of the community providers to help fulfill our mission to not only become a more consistent regional referral center for complicated medical and surgical problems, but also to serve all in our community and region, particularly the poor and vulnerable. We've done a number of things to help mitigate the burden. We can't really avoid the inconvenience or the difficult cases. This is just the beginning. I certainly want to do other things to impact a broader range of providers who are taking call. And you can read those, and I think that in the limited scope that they are implemented now, and it's fairly recent that we've had these assets at night to help with call for a certain number of specialties. I think it's really made an impact. And Helene Schultz, our own Helene Schultz, has led the effort to sort of organize and manage these teams, and has done really well. This last bullet point here, I mean, we're just starting to get residents, you know, and now in family practice, and hopefully soon in internal medicine, and maybe I'll come later on when we're a little bit further along with our process to get internal medicine residents, give you a little update. But it's probably unlikely that we'll have other residents that are not family practice or internal medicine anytime in the near future. So, you know, I want to just give you one example of how the primary care community in Providence Medical Group can help influence behavior to help fulfill our mission. And this is an eye chart, and I don't expect you to read any of this. But I did a little survey with the help of a number of folks, Betsy and others, to kind of just gauge in one specialty that we refer outside of PMG for orthopedics, in a recent 10-month period, just kind of the volume of outpatient referrals that are generated by the 90 PCPs and also the walk-in providers at PMG. And this is a bunch of mumbo-jumbo, but the bottom line is there are about 6,000 orthopedic elective outpatient referrals per year. And that works, and that works out to about 125 per week. That'll keep a lot of people busy for some time. That's a big number. And when you add the volume that we generate to the community through our emergency department, it's even a bigger multiplier. And so, you know, I think that we're going to face some challenges probably in the next few years as reimbursement and just sort of the medical economics get tighter. We're gonna likely face some challenges in our community to care for those who come to our emergency department who are vulnerable, sometimes poor, and need care. And so I think that it, you know, may be important to help align those in our community to the fact that, you know, there's a lot of work that comes electively through Providence Medical Group that would, you know, it's important to keep that going, that we keep sight of our mission and values as we, you know, direct those folks. So, you know, I think that individually and collectively, you guys have the power to influence these referrals to our community specialists and help support our mission for these difficult and inconvenient cases. And, you know, I wouldn't underestimate your ability to influence these. And I think it would be good to remember the words of the poet Marianne Williamson, who said, "Our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. Our deepest fear is that we're powerful beyond measure. It's our light, not our darkness, that most frightens us." And I think that applies to us maybe, you know, collectively, but also individually. I mean, I think that we as people of Providence, if we stay true to our mission, our light will help, you know, shine brightly across this community, and we can help all citizens in our community. I didn't mean citizens meaning U.S. citizens. I mean just all people who live in our community to you know, have the health care that they need, and we can also help our community partners help us with our mission here. So that's really all I had to say. It's nothing too profound. I'd love to hear if you guys have any comments or questions about any of this. Yeah, Jimmy?
Jay, what's the ask for primary care then? Is it to refer less people to the ER, or is it to?
There's no ask. This is just informational. I think that when I saw how many people were referred out into the community for orthopedic services, I was shocked. I mean, that's a big number, and so there's no ask now. We're sort of doing okay, but I sense strongly that going forward we may have challenges. Our poor and vulnerable population may have challenges accessing the specialty services that they need through the ER. And if that were to happen, I would think that we would want to, as a collective voice, say, we think it's important that you all help us with our mission, and we will, we will help encourage our elective patients to seek care from those who will help us with our mission. I mean, that's sort of, yeah, but there's no ask now.
So ideally, referring more to outpatient providers than send to ER, is that?
Well, I mean, we want our patients to go where they get the best care at the lowest cost. So if they need to go to the ER, they need to go to the ER. The ER is not really the point. The point is that there are barriers, as you know, sometimes to patients getting the follow-up care that they need in our community. And I want to, with your engagement and partnership, want to help those folks who need our assistance get in to where they need to go for their care. And it's not so much, and many of the patients that are sent to community providers, as you know, those who are insured have no problem. Let's just be real. Those who are poorly insured or not insured have real problems. We see everyone. We want everybody else to see everyone. And so I think that we have to, it would be most effective if we spoke with one voice to our community, saying we will encourage our patients to, all of our elective referrals, to go to places who will help us see everyone in our community, including the poor and vulnerable. Does that make sense? I've said a lot of words, and I'm not sure I made the sense.
I feel like you're trying to say something, but kind of walking around the words. Is there like
Probably
calling a spade a spade? Is it we need to talk to our other colleagues that aren't like in other practices besides?
Well, and I don't want to jump the shark or be premature about this right now. I'm sort of just giving you information now. No, I don't think that there is an action item today. Okay, and I don't want to say that there is, but I feel like and I'd love for Jim and Jeff and others to chime in. I mean, the burden is now born, and I think that may get worse. And I'm just trying to raise some awareness. Is really all I'm trying to do right now.
So Jay,
Yes.
so I think, and I can't speak on behalf of the group, but I think most of us who work for PMG like to send our referrals and support the specialists in our community with a baseline assumption that the care is great, whether they go to Happy Ortho, Sideways Ortho, whatever, that the care is great. So
Yeah.
that's an understood baseline. That has to be there.
Yeah.
But I think that most of us, operate under a philosophy that if you are going to care for my patients, you're going to care for my patients. Just like I care for people blinded to their insurance. It's a Providence way we work, right?
Yeah.
So absolutely, I want to support those specialists in the community who are going to take care of my patients. Not my commercial patients only, not my Medicaid patients on a 1 every 12 months,
Yeah.
care for my patients. Which I think is kind of what you're talking about.
Yes,
And
precisely.
so for them to care for my patients, that means whether I'm referring them as an outpatient, whether they're hitting the doors of the ED, whether they're admitted at the hospital. So whatever that place of care is that's most appropriate, I want to know that Happy Ortho is going to be part of the care plan and take their equal share. What we don't know, a lot of the times I think, is is Happy Ortho taking everyone? And that's a tricky thing. So I think that if you can provide PMG with information sometimes, so we know, because that has changed. There are groups that have stepped up more, there are groups who it comes on and off, there's groups that 1 month they see your Molina patient and the next month they don't. So it's a changing environment, and I don't know that we as individuals who write the referral can necessarily stay in front of that.
Yep.
But my ask at least would be, and I think maybe others would appreciate it, is, we need to have that information in front of us, because you're right, we can direct patients with the assumption that we're gonna get great care.
Yes. You said it better than I did. I mean, I think
I wanted
that.
to just,
Yeah, right.
Distill it. And we can provide you with that information, because we know who's taking what insurance. Now, and it changes, but usually it doesn't shift that much. So we can talk about how to do that, so you're at least informed about the choices you're making.
so if our current referral pattern is supporting a lot of folks who don't participate in the community, then we need to know.
Yes, I'm happy to provide that.
Jake, you might mention that the hospitalist ortho team contract is through Western Washington. I doubt many of you know that.
Right. Yeah, so we have an orthopedic hospitalist team, and they are currently employed with the Western Washington Medical Group, but they are sort of managed by PMG. It's complicated.
And they see everything.
And they see they're hospital-based, they just see everybody.
They follow up with them in their clinics, so they don't.
They do,
Oh, that's good.
they do.
Because Dr. Scott too, because the only thing close to ortho that we have here at PMG is plastic surgery.
Right.
Doing some hand things and stuff, but I don't really have a good understanding of what they really do or want to see or don't want to see. And we get some feedback from them as far as what we really helpful.
Yeah.
Yeah, that one's pretty easy. My partner Sam and I, and Jeff Scott with plastic surgery, we'll do any hand fractures, nerve injuries, tendon injuries, any trauma, any trigger digits, carpal tunnel, nerve compression, cubital tunnel, basically any hand. Yeah, exactly. So there's only rare conditions that we would refer out to a sub-specialist. But we know we're locals and we know the local hand network pretty well. So like certain things like wrist arthroscopy, blade arthritis, specific procedures we would send out maybe to the someone at the U, or it depends on which condition, but we can quarterback all that and triage that. We're happy to do it. So pretty full service hand-wise, trauma, like you said. I don't envy your job, Jay. Man, just listening to that. I mean, I think maybe someday, it's. I was just going to say a couple things about ortho specifically. My take on it is, I think the hospital has been very accommodating with orthopedics. I think perhaps maybe too accommodating. I don't mind overstating it. But they've gotten down now where they take call, they're paid to take call. They've got nurse practitioners at night answering all the calls, handling all the consults. They've got ortho hospitalist guys ready to take on the cases the next day. I mean, I'm not sure what they're paid to take call for much anymore, other than perhaps provide outpatient coverage like you're asking for.
Yeah.
So by the rules of the ER right now, they're supposed to have to take those, even if they're Medicaid or uninsured. We know those rules well, and EMTALA and all that. But if you're suggesting those rules are going to change and they won't have to do that, that's scary. But maybe if what you're really suggesting is that instead of that, they may pull out of sort of even covering the outpatient referrals from the ER, which I think is just easy. But if they did that, they still have to certify an outpatient, ASC. They have to have a hospital that privileges that. So you still have some levers at the hospital you can turn for these specialties. Yes. But you're adding a lever tonight by just saying, hey, primary care docs, help us out. Please understand if there are people who are not behaving properly and taking, the poor and vulnerable, please look for other options that are going to provide high quality care, that are not going to have bad behavior through the guides.
Thank you. Yeah. No, you said it much better than I did. I probably, like Jay said, maybe I was dancing around a little too much. But I mean, this is just a conversation I want to have with you all, and you know, you guys are so steadfast in serving everyone, and it's not easy, but I think that, you know, you all have a lot more power than maybe you realize, and particularly collectively. And I think that we can use that to help all of the people living in our region. That's all. All right, thank you.
Clinical pharmacy update. Kate and Amina.
All right, so our clinical pharmacy update for this quarter, we're going to talk about the new 2019 opioid prescribing WACs, so the new rules for prescribing opioids here in Washington. And there's a lot of new requirements for opioid prescribing, so we'll try and get through it pretty quickly, and because we don't have too much time. So some common misconceptions that we often see are primary care providers can prescribe opioids with a high MED, even MEDs at or above 120 milligrams. So you can certainly prescribe, you're legally authorized to prescribe high doses like that. But the goal to remember is that treating with opioids is to use the lowest effective dose. And so occasionally that does mean that higher MEDs are clinically appropriate. It's just especially for those patients that have been on high doses or moderate doses for years and years and years, to just see what a moderately lower dose, how effective that is for the patient, to at least try and then document what the outcome is so you can help justify their current dose. So some of the intent and scopes of the opioid prescribing WACs are that opioid prescribing must be based on clear documentation. The validity of the treatment using opioids is based on available documentation, not just what or how much you prescribe. And that pain is multifactorial, very complex, and the Department of Health just wanted to make sure that providers are assessing all of those different multifactorial issues. And so the summary is just documentation. And so to kind of push that, they created a lot of WACs with a lot of requirements. And so that's what we're going to talk about briefly today. So some of the exclusions for these rules, there are 4 different categories of patients. So patients with cancer-related pain or at the end of their life on hospice, palliative or other end-of-life care, inpatients, and also procedural medications that are administered don't fall under these rules. So a few notes. Every provider type has their own set of WACs and they differ slightly, which is very frustrating, but that it is how it is. Our PMG Northwest recommendations and guidelines, our tools, and the smart phrases have been normalized to suit all provider types. So if you use the smart phrases, you should be able to check off all the boxes that are required for opioid prescribing. And the Pain Committee strongly recommends that you do review personally the WACs for your particular degree to make sure that you understand all the full details of prescribing, because there are some nuances and special scenarios that aren't included in our summaries. So some of the one-time rules for all providers to do. All providers must be registered and have access to the PMP. Again, these are the rules as laid out by the Department of Health in Washington. So if you prescribe any controlled substance, anything from a C5 through a C2, you have to have personal access to the PMP. You can still delegate your MAs or nurses to pull the PMP for you, but you yourself need to have access. Continuing education requirements, MDs, DOs, and PAs need an hour of CE regarding opioid best practices or the new opioid WACs. RNPs need 4 hours of opioid best practices, and it's due by the end of the first full CE reporting period after the start of this year. So whenever your next CE reporting period ends, that's when the clock starts ticking. You need to fulfill these CE requirements by the end of that next period. So everyone has this summary of the WACs and prescribing rules on the table. And we'll also email this out to everyone so they have it available to them. So this is a checklist summary of what the prescribing rules are. And there are a lot of them, as I said. And again, it is what it is, unfortunately. I think it has the best of intentions, but they are very specific requirements. And so to kind of help with that, we wanted to briefly go over it, and we developed a bunch of smart phrases that we'll also quickly go over. So some of those always rules that apply to all pain stages. So acute, subacute, and chronic pain, are checking the PMP before you prescribe any opioid. You must document that you checked the PMP. If you notice anything weird, document it. Considering alternatives for pain care, alternatives to opioids whenever it's appropriate and possible. So whenever there's an opportunity to use something else or decrease the dose, that's a requirement. Education of the patient to educate them about the risks of opioids, secure storage and disposal of opioids. We have a smart phrase for that. PMG Northwest Pain AVS, whenever you're having an office visit with a patient and you prescribe an opioid, if you drop that in, that'll check that box for that rule. Prescribing naloxone is required, or confirming that a patient has a current prescription for naloxone if you're prescribing an opioid to a high-risk patient. And this, I think, is the most onerous rule of them all, but co-prescribing. So if a patient is taking any one of these 5 types of benzo, barbiturate, sedative, carisoprodol, or non-benzo hypnotics, so like Zolpidem, if an opioid is prescribed on top of that, you must document the discussion with the patient of the risks of that combination, your medical decision-making about the risks and benefits, and you have to contact the other prescriber, if it's someone else, to document a care plan about risk mitigation with the use of the medications. Again, I know that's a lot. That's what the rule currently says, and so we just wanted to share that with you and some of the tools that we have to help. So for the acute pain rules and documentation, there's a couple of smart phrases, one for the HPI section, one for the plan. For acute pain, it just checks off some of the boxes. If it's a follow-up visit for acute pain, there's a separate section that can be deleted if it's just the very first time a patient's being seen. The drop-down looks a little bit crazy in this format, but when you're in Epic, it has a drop-down menu that helps you choose the appropriate plan for your patient. And also this section down here in blue text with these curvy brackets around it, when you F2 through your note, it acts kind of as a wild card. It's just a series of checklists to help remind you of some of the new prescribing requirements. And when you F2 through it, it highlights it, you hit delete, and then it's gone. So it's not a permanent part of your note, it's just kind of some gentle reminders of what the requirements are. These are kind of all the areas that correspond to those boxes on that summary sheet in front of you. So kind of the same thing for subacute pain. Again, a lot of boxes to check in the requirements, but these smart phrases, if you use them, should help you check all those boxes. So again, it covers all those different things, and again, there's the wild card at the end that helps remind you of all the little things that you might not necessarily document. There are also embedded hyperlinks, so for the UDS, it opens up the tool directly from Epic about which patients need to have a UDS checked and how to interpret it, as well as naloxone. That link opens up the tool for who needs naloxone and how to order it in Epic. So hopefully those will help you out.
Right, and for chronic pain. So the tools for chronic pain are not new, but they have been updated to not only meet the guidelines and requirements from the CDC and AMDG, but now the new WACs. So the chronic pain annual smart phrase is required for any patient that is on opioids for 12 weeks or longer at that point of transition, and then once a year afterwards. So this isn't new, but parts of it have moved around to be consistent, and again, meeting all the parts of the WACs. There are also the short HPI and the short plan smart phrases for chronic pain to throw into a note in between those annual visits. So just a short, again, meeting of the requirements. And a reminder about pain consults for chronic pain. So they are mandatory for patients that are on an MED of 120 and up. But this can come about in several ways. So it can be an office visit with a patient and a pain specialist. It can be a consultation provider to provider. You can utilize telephone, audiovisual aids, but it must be documented, whatever manner it is done. And this doesn't mean that patients need to be entirely managed by pain specialists at this point, but just a consultation is needed. There are some notable exclusions, so if a patient is tapering down on their MED, they don't need this consult. If there is a temporary dose escalation for an acute pain situation, but then it goes back down. Or if it is documented that the patient is functionally stable and they do have pain control, so they are achieving that 30% or more increase in pain and function, or decrease in pain and increase in function, excuse me, with the opioids, and their opioid dose is stable, then they also do not need this consultation. For episodic care, so if a chronic pain patient has an additional acute issue that comes up and they see a provider that is not their primary pain manager, then there are requirements, so check the PMP and document any concerns that may come up. Adequately treat the pain, whether that be by an additional small amount of opioids or other means. If opioids are provided, then limit the quantity so that they just have the minimum amount needed till the time that they can get to their primary pain prescriber. And then finally, communicate with their primary pain prescriber what the plan is and what's going on. And here is just a summary chart of all the SMART phrases, new and old, for chronic pain. So this comes out of our December-January newsletter. It's available online, and I think we can email this out again if it's helpful. But just to point out, the PMG NW Pain ABS is new. The acute pain SMART phrases, subacute pain SMART phrases are new. The chronic pain ones have existed, but they have been updated to meet these new requirements. And so in EPIC, there are two prefixes for the pain SMART phrases. For the new acute and subacute, it's .PMG NW pain. And for the chronic, it's .PMG NW chronic. And then you should see all of them pop up. So they should be shared with all of you. If for whatever reason you don't have access, let us know and we'll fix that ASAP. But we highly recommend that you don't make your own versions of these because we will be updating them as the laws or MACs may or may not change. And here is just the summary PMG NW pain management recommendations. So this also is in the handout at your tables and available online. So this summarizes all of the PMG requirements and has been updated with the new WACs. And it is a requirement that primary care providers sign an attestation that they have received this and understand it. I think a while back in fall that Deb went around to the clinics to provide this. So if you're not aware of that, check with your clinic lead and they can get you looped in. And then just as a reminder, the Opioid Assistance Committee exists, so if you need help on a particular patient, you can just send a staff message to this pool and we will take a look at it the following month. And before we quickly move on, if you have any questions on this or would you like us to come out to your clinic to go over this in more detail, we are happy to do that. Just please reach out. And then finally, a quick reminder about diabetes resources for patients with type 2 diabetes at PMG. So we do still have that diabetes class, referral 144A, so it's the same as the care management referral. In the comment section, you just F2 down to the diabetes group class selection. And then our PSARs will reach out to the patient and schedule. We also have a smartphrase.pmg NW class info that just pops in the diabetes class flyer into the ABS. And we also have the pharmacist-assisted diabetes management service. So this has a new referral, so we're no longer using that smart phrase. It's actually a referral in EPIC, ref 202VB. So that is available as well. We are currently doing data analysis for both of these services, and we're finding that both are associated with an improvement in A1C control, and with patients that continue on with their pharmacist program, their A1C drops by an average of 3% points. So we're excited to see what that data looks like moving forward. And then as always, if you have any questions, feedback, requests from us from any of the stuff we do, please let us know. And if you have any questions on the laws, and if we have time, we'll also be around at the end.
I have one odd question, because I always thought that you gave your CAD for 90 or above, but this is 50. So is that changed, or is that always the case? That you just give for 50?
Can you say the question out loud, please?
Sure. So the question is naloxone for an MED of 50 or above versus 90 or above. So based on the CDC guidelines, we had started kind of endorsing using that at 50 and up. Yeah. So it's also 50 and up, or if they're on a concurrent benzo, or they have untreated sleep apnea, or they're high risk in any other way.
Yeah, I know initially when PMG Northwest came out with our pain management recommendations, the MED level was 50. That's one of those details that differs depending on what type of provider you are. Some are 90, some are 50, but again, to normalize it to everyone and to stay consistent with our previous recommendations, we're still recommending 50.
Do you know how much that costs currently to get confirmation?
I haven't looked recently. Most insurances are paying for it now though, because it's definitely a big issue currently.
Do the insurance also decides on if they're going to pay based on their MED, or they just, if you prescribe it, they'll prescribe it? They will cover it.
I don't know specifically. I know that anyone can receive a prescription for naloxone, not just people taking opioids. So if it's a parent of someone of a child or adolescent who might be at risk of opioid overdose, you can issue a prescription for naloxone to the parent, and some insurances might cover that. So it all depends on the patient's individual plan.
And we kind of anticipate that with this being in the WACs now, that insurance may change in the upcoming cycle and probably will have better coverage, but we'll have to find out.
So for acute pain treatment, if any narcotic is being used, we use this documentation. Is it just the documentation of the decision making, or is it entire visit note, that smart phrase for the acute 0 to 6 patient guide?
Yeah, so it's something
Like
that
if
you
have a back pain strain, you use your back pain thing, then we also use this.
Right, good clarification. So the question was, is this the note itself or is it something you drop in? And this is something that you drop into your normal note. So you're still required to have your normal H&P and your the physical assessment and everything, but once you decide, okay, an opioid is best for this patient, then you can drop this in to check off all those boxes that are required for acute pain prescribing.
And these are new tools, so if you have suggestions for improving this, please let us know.
This is just a little nuance, but when I use this Rep 2202BB, will it say diabetes, pharmacy assistant, or will it say anticoag? Just because the picture says anticoag, so if that's a tricky thing, then we need to know the nuance, or that's just wrong screenshot?
So it will send it to the WEV anticoag pool.
Okay, so if I see anticoag when I use this referral, I can,
Don't freak
it's still
out.
going to be diabetes?
Yes.
Yep, yes. The anti-coag clinic is now the medication and anticoagulation clinic, or, I don't know. And so it was renamed, we weren't able to rename it in Epic, and so the Epic department is still the same, but it'll cover any chronic disease states that the patient's referred for.
Do you have any recommendations around a patient who's a chronic pain patient who then gets a cancer diagnosis, whose MED is above 120? Or at?
These no longer apply if they're being treated for
the
cancer pain.
Cancer diagnosis could trump
Yep.
the pain diagnosis.
That said, if someone has a cancer diagnosis and then they are cancer-free after successful treatment, then these rules would apply.
And are there pain specialists in our community who are doing phone consultation for that MED of 120? Like I have a patient who's there and I've tried tapering her down and she fails and we've documented but I haven't had her seen, I don't have an annual pain consult on her chart anymore because it's gone by. So I was going to tell her she should go be seen again. I'm not sure if it's a good use of her time, to be honest, but.
Well, that's just one really important thing too, is it's not an annual pain consult for an MED over 120. It's a one-time ever.
Okay.
And also you can just document functional stability and you don't, if there's no reason to consult pain, please don't. If it's useless and just checking a box, then document functional stability.
Okay.
So it's not annual.
Okay, so that's once ever.
And it can be a phone consultation, so providers can call. I know that UW has a hotline that's available for free. I called it today and I'm still waiting for a call back regarding a patient for recommendations.
And you just document that phone consultation.
Yep,
Okay.
exactly.
As long as it's documented.
Yeah.
Thank you.
Just a piece of information for those people that have either, people don't have insurance or they're underinsured. They can go on GoodRx.com and naloxone anywhere from $20 to $40 depending on where they go for pharmacy.
So
that's not the
So, yeah, GoodRx.com has a lot of coupons for people without insurance, and
Or
so.
with
Or with insurance.
Or with insurance.
So it sounds like they can go, and naloxone has a $20 to $40 price tag with the coupon from GoodRx.com.
Yeah, so regarding a phone consultation, so will encourage you to do a case presentation for your chronic pain management patients, and they're dying to get cases, so they're like here almost every week. So, and they will reimburse you $100, they'll give you your patient $100, and it will meet the requirements for the consultation. So, but there's a way to get into the UW Pain network. So I find it very helpful. I mean, I'm not using it for a patient, but the tactics are helpful. But that's also a way to kind of meet your requirement without your patient having to go there.
Yes.
I don't write naloxone often, but when I do, and you type it into Epic, it's like this long for choices. So my question is can you guys make actually a clear, like, MEG greater than 50 naloxone intranasal selection? Because it always takes me a little while to find the right naloxone.
Yeah. So in our tool that's in the blue text, so if you click on the naloxone link, there are 4 different formulations available. So if the patient would prefer intranasal or an IM injection or a vial and syringe, there are 4 different standard ones available, and it tells you exactly what the order number is and what to write in the SIG.
And that's under the PMG NW pain on the right, is that one?
Yep, so any of these PMG, Northwest Pain, whatever, they all have this blue text, and I believe they all have the naloxone hyperlink embedded in the blue text.
That handout is also available online at the Providence SharePoint page under PMG, and there's a giant green chronic pain button, and you can find the naloxone handout there as well.
The last dot phrase that Deb told me about that's pretty invaluable to me is PMG NW post-op pain, and that outlines pain expectations and treatment for post-op patients, so I use it a lot. All the primary care providers could even do that for, like, they know they're going to have surgery. It helps them out.
Yep. And the post-op smart phrases, we're still working on updating those for the new WACs as well. But I know we've met with Dr. Morandi to discuss that, and we'll be presenting at the next specialty meeting about these new rules.
Will the MLB just substitute naloxone like the Monroe Pharmacy?
Yes, so yeah, if a patient's filling at one of our 2 pharmacies, so either out in Monroe or MOB at the hospital, we have a therapeutic substitution protocol. So if it's coming from one of our providers, we can legally substitute to a different product that is preferred by their insurance without having to call you.
Anything else we can answer?
Like Irina said, we'll be around through the end of this meeting, and so if you have any other questions, feel free to just come over and chat.
Miriam from Express Care. There you are.
Hi, everybody. I'm Mary Levy. I'm the clinical lead for the Northwest Washington region of Express Care. I just wanted to do a very quick update on Express Care, just kind of remind you that we're here and we're available for your patients and kind of give you an idea of what we're like for anybody who's not sure. So we have 4 clinics in our region. They are embedded in Walgreens, so we're generally right next to the pharmacy, and we kind of share the same chairs that the patients sit on, either for us or for the pharmacy. We have 4 clinics. We actually just closed our 5th one, which is at Clearview. Primary care is going in there. So we have 4 clinics now in Mukilteo, Murphy's Corner, Broadway and Everett, and Lake Stevens. We're open 7 days a week, 8 a.m. to 8 p.m., 365 days a year. So we're always there and available for our patients. We do same day or next day appointments. And there are various ways that you can schedule. We have been working with primary care offices to be able to directly schedule with your PSRs at the front desk. They can directly schedule on our schedule. We also have a call-in. The PEC takes our phone calls. They make appointments for us. You can book appointments on the website through an app on your phone. And we also do take walk-in patients for the next available appointment. So lots of different ways that you can do it. This is just what it looks like when you go online or even in the app. You can see that we have 20-minute appointments throughout the day, and you just pop your name in there. Oh, also through MyChart, anybody who has MyChart set up can make the appointment directly through MyChart. Just a basic set of info about our services. We basically do minor acute care, so sick visits, which you can see up here in the corner, you know, URIs, UTIs, rash, all that kind of stuff. We also try and do primary care support as much as we can because we know it's really hard sometimes to get in to see your provider. So if somebody needs a medication refill, we bridge them until they can get in to see you. Or a referral for something. We also do sports physicals for the family that realize they need it today for sports tomorrow. We do those as well. And then we do minor procedures, so very simple lacerations, INDs. We do like a few IM injections. Things that are outside of our scope, we generally don't do controlled substances. We definitely don't do refills for chronic patients there. And we don't really do like acute care treatment that would be a controlled substance. We don't do significant cardiac or neurological workups, so you know, chest pain shouldn't come to us. Concussions really shouldn't come to us either. We don't do IVs and we don't have any imaging. So those are all things that we would recommend that you refer the patient directly to the walk-in clinic or to the ED depending on how significant it is. And then this is just a quick picture of what it looks like for anybody who hasn't been to Express Care before. So the one on the right is the waiting room area. We have 2 rooms that we use as exam rooms and a little kiosk tablet there that people can sign in on. And then this is the inside of the room. Everything nice and basic all in one little mini room that we hang out in for 12 hours a day. Does anybody have any questions about Express Care? Yeah.
I have one. I noticed on occasion due to staffing that an Express Care clinic has closed. And I wonder at what point when you feel you'll be able to have enough staffing to accommodate, because of course if we rely on it and it's closed, it's difficult.
Of course, yeah. We are actually cross-training all of our providers to work solo. Because sometimes some of the reasons we were closing is because we didn't have MA support and the providers weren't able to do all the registration and everything themselves. So we are hoping to mitigate that issue by sometimes having a provider work on their own once they really know how to do that. And then we're also continuing to make sure that we're fully staffed as much as we can.
Yeah. When you do injections, do you do things like, what kind of injections do you do? Toradol or anything like that?
Yeah, we do Toradol and dexamethasone. Those are, we also do gonorrhea treatment, so ceftriaxone. We have nebulizers for albuterol, asthma.
What's your wait time relative to the walk-in clinics about?
So we're appointment based, so it's same day appointments, so like you can either walk in and if we don't have any patients, we'll see you right away. Otherwise, we'll schedule you an appointment for like an hour later or 2 hours later. But generally, people don't really wait very long. We have a lot of slots throughout the day. It was pretty busy in flu season, even through a few weeks ago, because as we all know, flu season was late this year. But we do have a lot of slots now. And just a quick shout out, we have virtual service as well, and we sort of support our Express Care virtual team as well. So if you do find out that our clinic is closed and the patient doesn't want to go as far as one of our other clinics, Express Care virtual is an option too.
What percentage are without a primary care physician, and how do you handle potential handoff?
We do see a lot of patients who don't have primary care, and we try as best as we can to refer them to primary care, especially within Providence. I don't know the exact percentage, but I would guess maybe even 50% or more of our patients don't have primary care. And we have a referral code in Epic that we use that sends them to the scheduling referral team, and then they get a phone call to try and set up primary care within the system. So we try and promote that as much as we can.
So real quick, I do want to take a moment and respond to John's question. We were talking to Mike Waters, who runs the Express Cares and the Ambulatory Network yesterday, and he continued to emphasize that we have a really strong relationship in the Northwest with the Express Care clinics, and about between 35 and 40% of those patients are new. Many of those are commercial. 70% of those are asking for primary care, and we only connect between 25 to 30% of those to actually a PMG primary care doc. So a lot of the conversation was we need to start to focus on how do you create a concierge type relationship between those patients that are coming to Express Care, get treated, looking for primary care, and then how do you connect them back in a warm handoff back to PMG because they're looking for somebody. So
Absolutely, I think there's a lot of
place to focus for us now.
Yeah, a lot of work that we could do on that to make that better. But we are trying as much as we can for now. Any other questions? Great, thanks so much.
Thank you. Sean and Melissa?
Good evening. Last presentation. Okay, so Sean and I'm Melissa, nurse practitioner, program lead for the new HMR, which stands for Health Management Resources Weight Management Program that's coming spring, summer this year. All right, so okay, perfect. All right, so it's go through the slides here. It's part of the new suite of weight loss solutions that are coming. HMR is a private company that has 35 years of experience with weight management, and it focuses on diet and intensive lifestyle change. And it provides a medically supervised weight management program, along with a unmedically supervised portion. Uses education in the clinic and also online support, and then meal replacements as their diet. So meal replacements and shakes. Average weight loss is 12 weeks, 15 pounds in 12 weeks. And it's available for high-risk patients. So those that are going to need to be, you know, they have some diabetes that is, their medication's going to need to be changed, or hypertension, heart disease. So, you know, high-risk patients that are going to be put on a low-calorie diet that will need to be closely monitored. All right, and so really, what does it do? It is rooted in behavioral science, focuses on lifestyle changes, and one of the biggest takeaways is it talks about weight management is a skill. It's not something that you can just go tell someone to go lose weight and then come back in 3 months or 6 months. So it's actually teaching a skill and educating the patient. And so they offer very low calorie diet. Portion control is the big key, and physical activity, and that, you know, they have a goal of physical activity and it increases over time. And then weekly, one of the main, you know, I think support for patients are weekly classes, group accountability, and a coach. And yeah, so then they can learn from each other in the program. And so why are we doing it? There is the new healthcare 2.0 initiative. You've probably seen in your best practices, the obesity link there. So it's something that they're reminding you, have you talked about weight management with your patient? And so it feels that the need for a program there to help our patients, instead of just sending them out with this is what you need to eat, this is what you need to do, and come back and let's see how you're doing. And really will empower them to make behavior changes and prevent chronic disease, especially from those that haven't gone into that chronic disease yet. And okay, so yes, I said we're launching in spring, summer 2019, right? And yes. It will be we're going to be starting in North Everett Medical Office Building. And then we'll have the classes there or in the conference rooms on the basement.
Yep, basement of the medical office building is where the conferences will happen. There'll be a information session that'll happen where patients, once they get the referrals that come in through our patient engagement center, there's a flyer on your table that talks about it, that has an 800 number. And that best practice alert that's in Epic also triggers the number as well if you select the patient engagement center. They can sign up for an information session. It takes them an hour long. They hear about it, hear what the program entails, what the requirements of the program is. And then from there, if they decide to take either the steps of medical managed in clinic, managed by themselves peers, or on their own completely with no digital coaching, no nothing, they just want to go on the diet themselves and try it, there's 3 levels that they can try. And all of those will be happening during the classes, and then it's a weekly follow-up that they'll have for if they're on medical managed or in a coaching in person or via phone.
Oh, do you want to talk about
Yeah, you may hit the cost?
Yeah.
So the next question is always like, one of the biggest things, so we did present this also to our specialty and our primary care councils, and one of the questions that came out of both of those is what's the cost? It is self-pay, which means we do not bill insurance for this. Everything is set up where the phase 1 with the very low calorie diet or a low calorie diet, and that's if they're only using the HMR meal replacements for this, is $9 a day for all 3 meals. So that's their daily intake of what's needed. If it jumps up to 11, the difference of that is if they need a lactose-free diet, because there's a special shake in the way that they do the mix with the lactose-free, it's a little bit more. The phase 1 of Healthy Solutions comes out to $14 or $18 a day, depending on how you want to do your vegetables and fruits, because that's where the cost that comes into addition from that $9 where it jumps up is if you're buying the organics, if you're buying the higher price, the stuff that's out of season, and so that's where you're going to get the fluctuation of purchase and price. There is an induction cost for this that once they do their sign up, and that can be between $70 and $170. And what happens with that is if they've had their physical already, if they have their labs, which is a BMP, a CMP, a thyroid, and a glucose, fasting glucose, I had to think of which of the 4 tests.
Probably cholesterol.
And a cholesterol, yes. If they've had those tests within the year or within the last 90 days, that drops the price down. If they've seen you in the last 90 days and had the physical, that drops the price down because it's a review only. If they haven't had anything and they're calling us from wherever the engagement center is, because they can also click on the HMR site itself and it directs them to Everett if they're in the locale, in the location or in our area. That might be where the cost comes out to the $170. Their fees are paid every 4 weeks in advance is the ideal, so they pay a month in advance for their classes. And that's the classes, the medical piece. The only thing that they're paying on a weekly price is their meals. There's what's called a minimum prescription, or a minimum that they need to maintain for those, which comes to about $170 if you get every single thing and all the hyper stuff where it breaks it down, because that's a 3-week cost, excuse me. So that $9 a day comes into that piece that they'll pay on that weekly when they attend their group classes. And they do the pickup and the monitoring and that piece.
All right, so this just talks about the different options for the plan. So the decision, the top one is a decision-free plan. So basically it's like, here's your food for the week. You don't make any decisions, this is what you eat. Really helpful for people that need to be, just not make any decisions, basically, so decision-free. And then the second one is the clinic-based Healthy Solutions plan, which includes the fruits and vegetables, and then the other 2 are, at home or self-directed. But it really shows you the amount of body weight loss with the really low-calorie diet, and then when it's clinic-based, it is better. They're getting that support and that accountability in clinic and with their peers. And what's the next?
And the Healthy Solutions at Home is also the one, if you've seen on the Northwest Communication messages talking about the Choose Well, for the employees that they can use. That is that Healthy Solutions at Home option is the same one.
And this, just talks about the average weight change from their initial body weight and then actually keeping the weight off, which is the goal, not just to lose the weight, but actually keep it off for the long term. And this, it's really small, hard for you to see, but basically, improvement in their labs, blood pressure, blood sugar, and then, getting off, how many discontinuing patients from their medications. And that savings alone for them financially is worth, what they're putting in, that they've seen with from the testimonials. And I don't know if you want to share personal experience.
There's one of the testimonials that comes out. There's and the patients will hear about it in the information class that they use. He's lost 300 pounds in a year and has kept it off and has maintained that coming off. Also came out of insulin, came off insulin. He was on 2 types of insulin, an oral and an injectable, gout medication, high cholesterol medication. He had said this was a 30-year-old male. So 30-year-old man, morbidly obese, and has came completely off of it. And he's like, the cost that HMR, that $14 a day cost that he has, more not having the insulin payments and not having the co-pays that come along with the medications, pays and covers it more, and he actually has a better quality of life now than he did when he was on the medications. And kind of going with the current diet that we have in America.
And you have the paper on your on the table there, but these are the ways to get patients connected.
And that 800 number that's on there, they can call into that one, and they'll script them. They work through a script, and it goes from I want to be seen in a clinic, I want to do something at home, I want to try something on my own. So there's various pathways that they can go on, and this is filling that gap between someone just coming into the clinic, getting nutrition counseling, and having to resort to the next step of bariatric surgery. So that fills that's what HMR is addressing, is that piece, or sometimes even getting them to where they are candidate for bariatric surgery because they're too much at this point. Their BMI, it's just unsafe to get them on the table for bariatric surgeons.
So if they do it at home, they still have costs out of pocket?
Yeah,
the food.
food. Yeah, the food cost is what they're paying if they do it at home version. They're only paying their they're only buying their meal replacements. They're not doing the coaching. The coaching is included with those meal replacements if they do the at-home version. If anyone is looking at doing the at-home, I myself, and that's kind of what Melissa was alluding to, I've been doing it now for about 5 weeks. The at-home version, through that time, it's been about 30 pounds almost that I've hit through that time in 5 weeks. And you actually eat a lot of food to the point that you feel you're overstuffing. The hardest thing is because we've all been taught, you can't or you shouldn't be eating after 6. Don't eat after 6. Only have water. You're trying to lose weight. Increase your physical activities. Stuff. And here, this HMR, all they're asked for is physical activity is 10 minutes out, 10 minutes back at a 3-mile-an-hour pace. So a very slow walk. Do that 3 times a day. That's the physical activity that they want you. The minimum of your goal for physical activity is to get them to that, and then do the food and eat. And if you're hungry, eat more. And it's not that you have to eat the meal replacement, it's have more fruits and vegetables. It's eating the right foods, not the foods that's readily available and at hand. Let's see, with this one, again, yeah, they hit the information. I hit on this real quickly. And they have different options to them, and we'll sit down at the information session and go over it with them. And but if it's in clinic, there is the intake appointment. They attend the weekly session. They pick up their weekly supplies of their food and meals at that time, and they're paying for it at that time. And as medications are adjusted, that's where, with Melissa in the clinic, the RN comes into play as their needs to be adjusted. providers are also included on that so that you see the differences and you see the changes as well, and those updates is coming through your patients.
Yeah, we'll send messages to their primary, depending, you know, how they're doing and what changes should be recommended or that they need to get into follow-up. Questions? Yes.
Okay, 3 questions. What is calorie count? The low calorie is one, how much calories you take in? Can they use health savings account? Number 3, how many weeks do you guys do this with the food replacement, and is there a transitional period to get back to regular food again?
They can do it for as long as possible, to answer as long as they want, ongoing. Low calorie, they have a really low calorie 500. I don't think we'll be doing that one. The next step up is 800, and then go up from there. And then, so we'll just determine on what kind of weight loss they need to do, and we can do that by how many meal replacements they need to get every day, shakes and food. And then HSA doesn't, it's food. You know, they don't pay for food. They don't pay for our food. That'd be great if we could go use our HSA to buy our food every day, but no, they do not pay for food.
It's a meal replacement.
Correct, but it's still
your
seen
food.
as food. That's why it's not covered by insurance, and we're using this as a self-pay. And the price is low enough to where it's designed that it replaces the cost of you having to go to the grocery store to buy the food, to going out to eat. If you look at the average person, I mean, you go to Starbucks and it's $5 to get a coffee. Right? So $5 to get a coffee 3 times a day, that's $15. Right there's your meal. And how many times you see people drive through Starbucks? Right, 8 times a day sometimes. Just because I have some friends that 8 times a day in Starbucks, and it happens, and they're getting the 16-ounce white chocolate mocha whip, extra 3 pumps, and all this stuff, and you're just like, wow, that's your 4th one today. Are you kidding me?
They probably could actually use the HSA though to pay the
office
office
visits.
space
Yeah,
and the lab, that kind of thing.
and the labs, yes.
Just not the food. They won't pay for that. So how long is the average time on the meal replacements, and what kind of maintenance do you keep? So meal replacements, I mean, some people can be on it for years.
Yeah.
I mean, it's nutrition, balance, but I think they have like a 3-month, 6-month, 9 months, up to a year. They follow people for over 3 years.
There's 3 phases to it, and it can run between 12 and 16 weeks for phase 1, where it's really scripted, and the term that they use is in the box. So you're using only the meal replacements or the fruits and vegetables. And that's that first to maximize the weight loss, because when you lose the weight and you start seeing it come off, it keeps the motivation going to continue on. And that's part of with that rapid weight loss piece that it comes out so fast in the 12 to 16 weeks. Phase 2, then they start introducing, you start introducing 1 ounce of lean protein, and they start having education of what is lean protein and what does that mean, adding on to the fruits and vegetables instead of using the meal replacements. And then phase 3 is continuing on with those portions, and that's going back to the quote unquote normal diet plan of going wherever, having whatever, and being mindful of what you're eating. And if you do have those, they rate foods between a scale of 1 to 10. And they have, we were at the conference, and at the time they were talking about 7s to 10s, and later on I asked, I'm like, I don't know what a 7 to 10 is. And that's those, like the red meat, the heavy, high-fat peanuts, nuts, oils, all those type of bases. If you have a bad day where you're having a lot of those, of that area, then you focus and you peel back down to the 1s to 3s to balance out, because you use less calorie, or there's less calories in there per ounce than when you're in the 7s to 10 world. And they get a lot of data, a lot of spreadsheets, a lot of like patient information that comes through. There's a lot of tracking, there's a lot of accountability, and that's the secret kind of the HMR is the accountability piece. And it's not a provider, it's not a, it's not the, it's their peers holding them accountable, going, okay, and it's a very non-judgmental atmosphere in HMR. It's not that you did something wrong if you fell off the wagon and you had a bad day and you fell out of the box and you didn't. It's not that. It's the supportive of, hey, we're all human, now let's get back into it and go back at it. Which is one of the differences of why they have a lot of success.
Yes.
Do you guys see teenage patrons or is this 18 and over?
18.
I think it's 18.
It's 18 because just the diet restrictions, especially if they're going on a very low or a low calorie diet. It's 18.
I'm working on like the ones at home with like the fruits and vegetables.
They might be able to sign
Yeah,
up
the
for
healthy
that
solutions
one,
or
but
phase or like a phase 2 modified.
Yeah.
They're just the at home. It's more of a just because it is. I mean the entrees are an average of about 200 calories. Is what you're having with entrees. So in a meal you're having. I mean that table would fill up. Your calorie count for the day is how much food you have.
It's a lot.
And it's like 1,200 calories that would circle on it, that would fill up around one of these meeting tables between the shakes and the meal replacements.
I have a question somebody asked me. What's the difference between getting a couple hundred calories in there versus what you do like Costco or some other place with
The planning
So it's-
and having to go to Costco and I mean, that would be hard. I mean, you'd have to pick the foods to make it yourself. This is really to help people. Here is your food for the week. You know, people that have not been successful in the past with weight loss.
Taste-wise and also with the shakes and the entrees, the vitamins, there's not a multivitamin that has to be taken on or more vitamins or they have to increase their levels. The vitamins are actually included as well with the shakes and the meals. So they do add the vitamins into that, so they're getting their piece. If they're on the very low calorie diet where it's the 500 restricted, there is pills they have to take because you worry about potassium and magnesium. And you don't want those levels to kind of go out, especially if there's a cardiac person.
What if a patient goes through the low calorie diet and, all of a sudden has gallbladder disease, and then either they go see you or primary care?
Well, if they have gallbladder, they need treatment, I'd send them back to their primary care provider.
Back to the PCP.
Yeah, back to the PCP.
Are the labs covered in your initial?
Yes, yeah, unless a lot of people have had them done, recently, or if they've had their annual physical, then those, we don't have to repeat those. But then we would recheck them at a certain point, probably 12 to 16 weeks after the beginning of the program. Any other questions? All right. Oh.
Is there any category of patient besides peds that doesn't qualify for this, like no diabetics?
Oh, no, pregnancy, it would be probably the only other.
Pregnancy and breastfeeding.
And breastfeeding. But other than that, there's no restrictions.
It's actually kind of tailored to the cardiac diabetic that's
Group.
Yeah.
That's who we want, who benefit a lot. So. All right, well, thank you very much.
All right, we're almost done. Thank you again to all the speakers. Big shout out to Cynthia. Where are you? She probably knew it was coming. Cynthia works really hard to put all this together, and I got to witness that over the last couple of weeks. So give her a pat on the back when you see her. She probably ran to hide because she knew I was going to do this. And then finally, there are some evaluation forms on your tables. Please take a moment to fill those out. And in particular, if there's things you want to see in the future, please write those down so that the organizers of this have some ideas as to what you want to hear and what we can get. We do have a couple minutes if you want, if there's any general questions or even other questions for other speakers. But if not, thanks for coming and enjoy your evening.